We're going to talk about the impact of federal Medicaid and Medi-Cal policy changes. And it is my privilege to introduce the moderator for our third session, Ana Ibarra, and she is a reporter at Cal Matters. Again, I urge you to look at her biography because she's threatened me within an inch of my life not to go on and on and on. So look at her body of work, and I'll let Ana take over then. Thank you.
Good morning, everyone. I hope you all are enjoying the conference so far. So for the next hour plus, we're going to be talking about Medicaid, or as we call it here in California, Medi-Cal. Specifically, we're going to be talking about the federal changes to the Medicaid program and what they will mean for states, for providers, for health systems, insurers, and of course, the millions of people who depend on this coverage. Now, Medicaid, as most of you in this auditorium know, is a massive program. There are more than 76 million low-income people in the US enrolled in Medicaid. About 15 million of those are in California. In California, Medi-Cal is the largest program in the state budget in terms of funds. It's a program, about $197 billion program. More than half of that comes from the federal government. Over the years, Medicaid has grown to pay for so much more than doctor visits and hospital stays. As an example, nationally, Medicaid is the biggest payer of nursing home care, which I found really surprising when I first learned about. It also pays for services like substance abuse treatments, medically tailored meals, and even housing navigation and supports. And states like California have taken every opportunity to expand who is covered under this program. California, for example, opted into the ACA Medicaid expansion and allowed people, regardless of their immigration status, to enroll. Last year, I attended the conference. I listened to panelists speak about what might be included in President Trump's budget reconciliation bill. And while we didn't know exactly what would be on there, I think everyone that spoke sort of anticipated that some of the biggest changes and spending cuts would be to the Medicaid program. And so now we know. The law that President Trump signed last summer is making sweeping changes to the program as we know it, both on the financing and the coverage side. H.R. 1 cuts nearly $1 trillion over the next 10 years for Medicaid, and the CBO estimates that somewhere between 7 million people are expected to drop off from this coverage. Now, to help us go over these changes and their implications in more detail, we have three very smart panelists here today. So let me introduce them. First, we'll hear from James Capretta. Capretta is a senior fellow at the American Enterprise Institute, where he studies and comments on U.S. healthcare, entitlement, and fiscal policy. He also serves as a senior advisor to the Bipartisan Policy Center. He previously held senior positions at the Office of Management and Budget and on the staff of 2 congressional committees. He is the author of U.S. Health Policy and Market Reforms: An Introduction, along with numerous other papers and articles. Second, we'll hear from J.C. Cooper, who is the president and CEO of Precision Health Strategies. Cooper is an accomplished healthcare executive with over 20 years of experience in Medicaid policy and healthcare delivery system reform. She is a proven leader in driving transformational initiatives at federal, state, and local levels, where she has served as the director of the State Demonstrations Group at Centers for Medicare and Medicaid Services, California's Medicaid director, and vice president of public hospital system. Thirdly, Young-Kyung Kim is the Chief Operating Officer at CalOptima. Kim is responsible for oversight and day-to-day operations of several CalOptima health departments, including customer service, information security, network operations, grievance and appeals, claims administration, quality improvement, senior programs, and Medi-Cal and CalAIM. She is charged with ensuring that these departments operate effectively, implement board-approved business strategies, and comply with all state and federal requirements. So, James, the floor is yours.
Well, good morning, everyone. Thank you for the invitation from those who are putting this conference together every year. Thank you for having me back, I will say. I did get to do this a decade ago. So in 2036, you'll be due to come back again. And by then, everything will be fixed, I'm sure. So anyway, it's great to be here. I'm pleased that I was given the opportunity to join you today. So this is a tough assignment. This is a forecasting conference, but thankfully the task is, to me, maybe has a little bit of looking back, and then maybe from that, what does that mean? So hopefully there will be a little bit of forecast here, but a lot of it will be what's going on. So, all right. So what are the main changes? Just to give us a baseline of information we can kind of work from. This is just sort of a rack up of the main provisions of the law that passed in July of last year, that was signed into law in July of last year. The one that has gotten the most attention is also the one that has the most significant fiscal consequences, potentially, depending on how it's implemented, but CBO thinks it will be consequential. These are all numbers from the Congressional Budget Office, which is the agency that advises Congress on the budget. So the Medicaid participation requirement, if followed and implemented the way CBO thinks it might play out, there's a lot of uncertainty around it, it would reduce spending over a decade by $326 billion, which is very, very substantial, mostly because CBO expects, of that number that was referenced earlier, of the people who would no longer be participating in Medicaid, a lot of them will drop out because of this requirement, according to CBO. So this is an important provision. The question is, does it play out the way CBO expects, and maybe some states expect, or does it play out differently? That's a big question. Maybe we can get into more as we go along here. The second big area is Medicaid provider tax changes. So I think we all know, this seems to be an audience with lots of people who participate in the provision of services to patients and the financing of care through various channels. Medicaid has been relying since the late 1980s. Many states do this. Most states do it. They use different ways of raising their share of the revenue through implementing different tax provisions on the provider community themselves, which they then later can compensate the providers for through various payment mechanisms, so that in effect they draw down federal funds and the provider community is no worse off. Yes, they had to pay the tax, but they got more money from Medicaid as a consequence of it. So this transaction has been the center of much dispute, a lot of regulation, a lot of legal changes. This is the most significant constraint, though, on it in a quarter of a century. So this will be a very big and important provision. I think it will be implemented aggressively, and it will force some changes on the states. Related to that is something called Medicaid state-directed payment policies, which is essentially, as many of you probably are very aware, a way of having Medicaid finance very targeted revenue sources using Medicaid funds for specific providers that are considered important to the delivery structure of Medicaid, using very elevated payment rates for certain services to draw down money that then gets compensated through a back channel and lowers the cost on the state. So much of this is paid for by the federal government, much like provider taxes. And the question is, how high can a payment for a service go in Medicaid? They've now capped it at Medicare rates prospectively with a transition period. That's a big change also, very much related to the provider taxes. Then there are several other changes of consequence, big, many in the state of California will be very big, but less dollar amounts across the country. Redeterminations now being reimposed on every 6-month basis, can no longer go longer than that. Cost sharing for the expansion population above the poverty line, and then new restrictions on non-citizen eligibility. Beyond that, this is a discussion about Medicaid, but it's hard to talk about Medicaid without also talking about the related provisions on the Affordable Care Act side. So I just thought I would at least put those down, because many people say, well, it's not just Medicaid. They also did a lot of changes that are similar on the ACA premium credit provisions. And and then there's consequential too. Here are the effective dates again, and the main provisions as scored by CBO as part of the bill. Again, there's a provision saying that most non-citizen eligibility is no longer allowable under the premium credit system. There are more restrictive and narrower special enrollment period criteria. There is a pre-enrollment eligibility verification. You can't put someone on the program without verifying that they actually are eligible. And then there's full recapture of overpayments. So there's more tight control over not just sort of saying, well, we overpaid you, but we're not going to collect it later. There's going to be a requirement that it all gets collected back. On the health savings account side, which is not really related to Medicaid and Medicare, Medicaid and the ACA, but also I think of relevance here, there's a liberalization of using high deductible plans in the ACA credit system under bronze and silver plans. They can be combined with HSAs. There's authorizations of more uses of the funds for direct primary care and telehealth as well. And then I think I heard in the previous panel some discussion about the Rural Transformation Fund, a $50 billion 5-year program for every state participating, except for the District of Columbia, to participate in this funding that can be used to change how rural health care is delivered. Now, just a couple of analysis points. I think it's important to understand on this provider tax provision, there's a lot of, I think, concern about it at the state level. But I think going forward, my own point of view on this is that these are the provisions in the law that got enacted that I was most glad to see being put into Medicaid. Just because the program had become untethered from basic integrity requirements to allow federal taxpayers to continue to support it with the loose implementation of rules that was not a shared and fair responsibility division between the federal government and the states. Some states took it to a very, very extreme level, and some states did a little bit. And you can't really run a federal program with such loose criteria on what qualifies as a state share. There are many states that would put out press releases. I won't name any. I just happen to be in one of them, but they would put out press releases that essentially would say to the provider community, don't worry about this tax, you're never going to pay it, okay? I mean, these were in the record, right? So, I mean, you have a lot of this going on for 2-3 decades. The program starts to lose its integrity. I think that's bad for the program over the long run. So even though there's dislocation from this provision, and a lot of people are upset about it, I think if the states really view something as a high priority that deserves Medicaid funding to the tune of $200 billion in the state of California, my guess is the governor, working with the legislature, can find the money somewhere if they really view it as more important than almost anything else. If it's not important, and they only did it because they could draw down federal money, then maybe one should say, wait a second. Wasn't it not important that the normal 50-50 share would play out? So my point of view on this particular one, it was long overdue. Now, one thing to keep in mind is the dollar amounts are pretty consequential. This is from MACPAC, which is the Medicaid advisory body to the Congress. And on this particular chart, what it shows is that over time, there has been a movement of much of the state share of the financing out of state general revenue sources into provider taxes. Now, what's the consequence of that? The bottom line here is that MACPAC estimates that about $60 billion a year, 5.4 percentage points of the total Medicaid spend, is associated with what they call, euphemistically, state financing tools. So in other words, on average across all the country, if the on average state share is 35% roughly in the official numbers, most states are really only paying on average 30%, and the federal government 70% because of these provisions. So can we run a program like that indefinitely? Probably we kind of can, but it is cause a lot of political friction. And, it's probably something that more integrity in the program is better than less. Okay, now to the other point, which is what's been going on in these coverage numbers. If you look at the data, the surge in enrollment in Medicaid and the Affordable Care Act premium credit structure really was incredibly rapid post-COVID. So they relaxed some of the eligibility criteria, and to be candid about it, the Biden administration very much wanted to put more and more people onto both programs. That was a priority of the prior administration. And they did it. If you look at the numbers, Medicaid really ramped up, as did premium credit enrollment. Of course, they had the enhanced subsidies as part of that. But the key here is how many people who ended up on Medicaid and the ACA credit system in this surge that occurred 20 to 2024 were newly insured and not coming from other coverage sources. And the jury's out on it, but the rough data, I think, points to the fact that most of the people had prior coverage, but if these subsidies and these eligibility criteria were available to them, they ended up going into the essentially zero premium plans they could get and moved out of their other coverage options. So if you look at the data, the uninsured between 20 and 2024 went down by a total of 0.9 million people, which is substantial. I'm not saying that any number is better than zero. So I want everybody to be covered. Don't get me wrong. But the very large enrollment increases from Medicaid and the ACA premium credits between those 2 years was 17.2 million. So, you're talking about, 16 people going from something else onto these programs for every one person that is going from uninsured to insured on a more steady basis. So is this a good thing or a bad thing? It's better to be paying, for a lot of people, of course, it's a financial matter, and of course, it's very important. But on the other hand, we also have to ask, how can the taxpayer system support what is something that can be sustained over a long period of time? So I think I'll stop there because I'm sure there'll be a lot of questions. And I do thank you for allowing me to be here today. Thank you.
All right. Good morning, everyone. So I'm going to bring kind of a state perspective, both across states and then California. And I think it's fair to say the cuts in H.R. 1 are the largest cuts that Medicaid has seen, obviously, since the ACA, but just ever. I think what it signals is similar to what James is saying. I mean, Medicaid is now the biggest M out of Medicare, Medicaid, and Marketplace. The growth that has happened in Medicaid is significant. Even financially, if you look at the trends over the last few years, the line is directly going up. And so what you're seeing for the first time is the federal government actually managing Medicaid. They've never really done it in that way. The Medicaid is about a federal-state partnership, to be honest with you, and there's been a lot of flexibility in that program. But when coverage is growing and the dollar is significantly increasing year over year, you're going to see somebody paying attention and managing Medicaid. Maybe people would approach it differently than what happened in H.R. 1, but essentially that is a big piece that's happening. In perspective, for example, on the financial exposure, and I'm going to go over these kind of four main areas. Some of the largest financial changes and coverage changes that we will ever see probably in the program, and will change the trajectory of the Medicaid program in the United States for sure. California, as an example, is estimating a $30 billion annual hit because of the changes and 3.4 million coverage loss in just California alone. Now that's across all of the coverage changes. There's 20 states that don't even have 3.4 million residents in their state. Just for some perspective of the size of what we're talking about. So yes, was Medicaid growing? Yes. Were the finances growing? Yes. Is the approach here? We'll see how it plays out, I think is what we would say. But clearly, accountability is definitely the tone of many of the changes. And I would say, someone who's been in Medicaid almost my entire career, I would have never designed the Medicaid financing the way that it exists and has existed. Nobody would draw this playbook. However, it also can't change overnight, or you'll have complete destabilization of the entire Medicaid system and healthcare system. So essentially what HR 1 is a de facto capping of the Medicaid program. It's not a block grant, it's not per capita cap, but it is definitely starting to put some guardrails around the finances of Medicaid in very, very real ways. On the financing lane, at least, it is cutting across red and blue. This is not just red states or blue states. It's both. Red, blue, and purple are being hit. In fact, some of the red states have some of the largest, dollars in these taxes when you look at the overall population that they're covering, the dollar coming in. So this is across the board, and I do agree with other people. I think they will be relentless on this one. I don't think this one's going to budge significantly in regards to how the provider taxes and the changes here. There'll be things around the edges. Some things may get phased out because you don't want to have the cliff. You need to have a transition, but by all means, this is something that actually blue and red administrations have not loved. This is not just the Trump administration who came in and said this. The Biden administration and other Democratic administrations have been signaling this is not the way to finance Medicaid for a long time. So everybody saw this coming. It just came very fast, very quick, and very real, is what I would say. It will have larger impacts on the healthcare system for sure. Hospitals will close, especially rural critical access hospitals will close. Some of the immigration changes in the way things are financed too will have great impacts on FQHCs because if you are changing what even FQHCs, the role they play for the uninsured or people with unsatisfactory immigration status, you're gonna see some destabilization happen in the system because you can't have all the players who used to cover uninsured and or the undocumented populations all of a sudden lose significant funds. So you will see squeezing definitely happen in the system for sure. And so I think that's one piece on the financing side. I think you're seeing a ton of just accountability, even on the out years, as mentioned, in regards to errors that were happening in Medicaid. They used to be waived, and now they're saying that won't happen anymore. There's just a broader focus on accountability when it comes to Medicaid. When it comes to coverage, I think this is an interesting piece because all trends before this were leading to larger coverage. In fact, we had more states doing continuous eligibility than we ever had before. And I'm not only talking about, again, not just blue states and Democratic states, even red states were understanding the value of continuous eligibility, whether it was just 12 months of continuous eligibility or longer for children. The research definitely showed there's a better return on investment if the duration of someone's coverage doesn't completely contradict the eligibility verification frequency, right? Because we're talking about low-income populations, their income changes and fluctuates significantly, and that makes people churn in and out. And there's a lot of research that shows churn is actually very expensive. It's expensive administratively, so you pay anywhere, there's research that shows $400 to $600 per churn episode. Well, in a state like California, even if only 10% churn, which is pretty low percent for California, that's $900 million annually to pay for churn. So a lot of people had actually looked at research and thought continuous eligibility actually saves money. So it'll be really interesting to see this play out in regards to, yeah, blunt coverage loss will save money as well, but the overall impact, not just for the Medicaid program, but the larger system, someone will absorb that. Commercial premiums will absorb that. Hospitals will have to make that up. You don't just lose the amount of money we're talking about in Medicaid and somebody else not pick up that bill. Yes, you will see some shrinkage, but I think it's really important to keep that in mind when it comes to the coverage pieces. So we have this huge trend of continuous eligibility, and then we're going now and states are implementing work requirements. I'll use work requirements, even though I thought it was really interesting the government couldn't just call it the same thing in both programs. SNAP calls it work requirements. In Medicaid, we have to call it community engagement. But at the end of the day, for today, we'll just call it work requirements. I left SNAP on here too because you're gonna have households impacted across HR 1 changes that will really impact people. You now have able-bodied adults on the SNAP or CalFresh in California side being hit with work requirements that were waived for a really, really long time in the state of California and many states. And then you have work requirements also on the Medi-Cal side or on the Medicaid side. And this is all going to come down to a data game because it has demonstrated with a lot of states who have tried to do this, Arkansas, Georgia, watched it very closely, that it doesn't really equate to if you're eligible that you receive coverage. The administrative burden that the system brings with work requirements is really what dictates it. And that's the friction that will cause from the pieces, right? So I am confident that most states are doing everything they possibly can right now. Maybe not all states, but most states are doing everything they can to do data matching. California, for example, has released their plan on how they will do data matching. The way eligibility works in Medicaid is this thing called ex parte. They're gonna pull in every single possible data feed they can across multiple systems to see if somebody is eligible. And then if they're eligible, to see if they're complying with work requirements or if they're exempt from work requirements. But unfortunately, because the systems are somewhat disparate, especially in California, where we don't have broad health information exchange, our data systems in California are actually quite poor, to be honest with you. The state will do everything they can to maximize all data feeds for that process, but there will be people kicked out of that process down to manual submission, which means they have to turn in paperwork to demonstrate that they are exempt from work requirements, or they have to turn in paperwork to show that they're complying with the new work requirements. And there's a lot still to be determined in regards to what that documentation will need to look like from CMS. We're still waiting for those regs to come down. So we know there will be coverage losses. I think it will get better year over year as data gets better and processes get better, but the timeline states are working under, it will be like everybody's taking the elevator down, you're gonna lose, and you're taking the stairs back up to slowly gain that coverage back. So the first few years, you're gonna see those big losses because people are gonna be working on improving. Look at Georgia. Georgia had really bad outcomes on their work requirements in their 11-15 the first few years. And as they started improving the data that they were using to determine eligibility, reducing the frequency of that check, they saw more people gaining coverage. So we've already seen the evidence around how it will take time for states to do some of these pieces. So really important. Also, there's a huge AI technology boom right now. I would just say the obvious. The reason why we're leaning on AI and technology is because of the administrative burden that this creates. And so you're having AI and technology come in to reduce that friction, which is really important, versus it could have been really good if we were just improving eligibility systems and processes without that. But still, you will have to, as a state, lean on AI and technology to not have these coverage losses. Lots of states right now, it is a boom. I have not seen anything like this in Medicaid for a long time. I actually think it will be good overall for Medicaid to have technology and AI hitting it the way it is, but it is expanding significantly. Every conversation right now in Medicaid is about technology, AI, leaning in. There are third-party vendors out here who are offering solutions to states to make this as easy as possible for individuals to be able to have and meet these requirements. So you will continue to see that. The other thing I would flag is in California, when you have this type of loss, we're talking about real uncompensated care. And we, red and blue administrations for decades have been okay with paying for uncompensated care. I don't think this administration is going to be wild about paying for uncompensated care. It used to be approved in 11-15s for decades, to be honest with you, and I just don't know if those days will be here anymore. In California, the way it happens is if you lose coverage, counties have an obligation under the 17,000 statute obligation to cover uninsured costs for certain populations. They can set the federal poverty level that they cover, they can set what services, but there is a requirement in California for uninsured to have coverage. Since the ACA, we had the lowest uninsured rates that we have had in this state, as an example. Most counties don't have their indigent care programs in place anymore. So you're about to have a coverage cliff with counties starting to say, oh, wait, what? Most people in the counties didn't even run those programs. I had the benefit of running an indigent care program at the county level early in my career. It'll be really interesting to see how counties are going to navigate the world in front of us. It'll be a big part of the budget, as we know. In California, people will be thinking about this. Dollars flow from the state to the counties for this. Is it enough? The expectation of coverage and benefit today is way different than the pre-ACA when these things existed before, and how they look at that and what they do. CHIAC has been putting numbers out there of what this could cost counties with the types of numbers we're talking about, millions of people potentially losing coverage. And that doesn't, and I will just flag, the 17,000 does not obligate counties to cover anyone who is undocumented. It is only US citizens, county residents, and within certain federal poverty levels that they can define. So it will be really interesting to see how we chart this. I'll quickly touch on 1115 demonstrations just because I think it's important for people to be tracking. It kind of is like a quiet thing under the radar on the Medicaid cuts, but having ran the 1115 shop at CMS, 48 states, DC, and 2 territories have 1115 demonstrations. It's about 37 to 39, depending on the year, of the federal outlays of Medicaid. It's a huge part of the Medicaid program. It's not going untouched, clearly. So budget neutrality is being changed. HR 1 for the first time actually put in federal law. It's always been practiced, but was never in federal law, that you have to be budget neutral in your 1115. This is how states do innovation in Medicaid, for lack of better description. They fund a lot of things through 1115s as well. Some states, like Tennessee and Arizona, almost their entire Medicaid program runs through an 1115 demonstration, as an example. It's a big part of it. And they're changing the rules. So there's a few things they did. It's the first time that they are going to standardize the methodology. You used to be able to negotiate budget neutrality. It would go in your STCs. And so states had variants. Starting in 2018, Trump 1 actually made pretty substantial changes to those methodologies, started standardizing it to the point where most states were going to lose the savings that they had gained through those demonstrations. And so Biden administration came in, they swung it back a little bit, but not too much. But one of the things that they did is expanded some of the definitions around things when you don't need to have savings to pay for them in states. It's called hypothetical, super wonky, won't get into the details. But when you eroded that with HRSN services and infrastructure, GAO has been pretty critical around 1115s and budget neutrality, saying, we have some fiscal integrity exposure here, and it needs to probably be tightened. So what HR 1 does is comes in, it says the Office of the Actuary now has to approve all of these. They've never looked at one budget neutrality workbook, for the record. You have to standardize the methodology across your baseline, what drives savings rollover, all of those pieces. And they defined hypothetical in HR 1. And historically, hypothetical was if you're providing a service for a population or a service that's otherwise allowable in Medicaid, then it's considered neutral, because you could have done that without a demonstration. But they changed it to and in HR 1. Well, guess what that means? States that are covering home and community-based services in their 1115 that wouldn't otherwise 100% be equal to a 1915C, super wonky, yes, terms that I'm using, demonstration, means they may need to have savings to pay for that type of demonstration moving forward. Well, guess what? Out of those 48 states, DC, and 2 territories, only 19 states even generate savings in their 1115. Most 100% rely on hypothetical expenditures, and they're getting kind of authority from CMS in that way. So it could be a very big change for a lot of states in regards to what they're covering, how they're covering it, and if those changes come. So those regs are supposed to also drop in 2026. It'll be really interesting to see. It's a sleeper, in my opinion. Obviously, I have a lot of experience in this space. However, I would also just flag CMS quickly came out in 1115s. The next growing trend was workforce. Workforce was one of the growing 1115 trends, and essentially they said, we will not fund workforce in 1115 demonstrations moving forward, and we will be ending all of these workforce demonstrations when they come up for renewal. They also ended DSHB, which is a very wonky financing piece. Trump 1 ended DSHB, Biden brought it back. Trump 2 ended DSHB within a few weeks of that. So no surprise, any state getting DSHB dollars was not surprised. Again, red and blue states getting these types of these initiatives. But those ended as well. So you're losing a lot of the mechanisms that you used to fund uncompensated care with, or these backstop financing pieces. They're all being kind of tightened in that way. So 1115 was a big way of doing that. It also is helping fund a lot of the infrastructure change that was happening. The other thing I would mention is the HRSN pieces. In California, we call those community supports. The federal government helped contribute to billions of dollars of investments in infrastructure across the entire state of California to build these up. And we know that at least some things are protected here because we moved a lot of our authority out of the 1115. California significantly shrunk our 1115. In my time as Medicaid director, we moved that out. That was to protect the program, to be honest with you. So it was very wise. However, the pieces that are in there, recuperative care and short-term post-hospitalization, California has released their renewal 1115 for comment. They're planning to move those things out of the 1115 into in lieu of services. And the only way you can do that is if you remove the room and board. So you have to remove the room and board portion of those dollars to be able to do that, because the only authority that you can pay room and board with is 1115 authority. And that will have a lot of impact, and that's out for comment right now. So you can see the state even reacting to the various pieces, and CMS hasn't even opined yet on HRSN policy yet. We know it's being deliberated right now because Colorado just got an extension for 3 months. We assume there will be some news on the policy soon. And the last piece I will mention quickly is the federal and state partnership has significantly changed. Medicaid used to be about flexibility. You're starting to see a lot more standardization. Data sharing used to be something states were never scared to do. And now by sharing information with the federal government means that ICE could also get access to undocumented information. You have this new dichotomy of putting expansion states against non-expansion states, something we hadn't really seen. In fact, we were seeing the largest number of red states growing into expansion, moving towards expansion, and that is essentially halted, especially when you're doing payments based on whether you're an expansion state or not. So it's 100% for the Medicare on the state-directed payment cap for expansion states, and non-expansion, it's 110% of Medicare. You'll also see a crackdown significantly on immigration, so targeting states. Again, states used to have the flexibility to use their own state general fund dollars on what they thought was important for coverage, and you're seeing a really big tightening on that front. And then program integrity is the last one I'll raise here. And it really is interesting because program integrity has always been a part of the Medicaid program. At DHCS, when I was there, it's actually the largest department that exists at DHCS because California is so big, but it's always been a federal and state partnership to go against fraud and to be taking fraud out of the system. California for a long time partnered with FBI and others because of the fraud rings that happen in a state this size. This is the first time where we're seeing the CMS actually point the finger at states, California, Minnesota, Pennsylvania. I think Florida is starting to get some attention on this now, pointing the finger at states as being misuse of those pieces. That is a very different tone and tenor. It's always been a partnership to go after fraud, waste, and abuse between the federal government and states. So again, the federal-state partnership is changing for states for sure. And what I think the biggest thing I would say is it's just a very unpredictable future. So a lot of the things and decisions being made right now are really going to change the trajectory of the Medicaid program. And so I tell everybody, walk slowly, use data, be careful, because decisions being made right now are really charting the future for where Medicaid goes.
Good morning, everyone. I'm Yoon-Gyang Kim with Cal Optima Health, and we are now going to move from the state level to the local level. And what do these changes mean for us, specifically in Orange County, where we have the opportunity for a fairly, I think, unique view of local impact. So why? Cal Optima Health is the reason why. So it's not just because I work there. Cal Optima Health is the single largest health plan in Orange County. We're a single plan Medi-Cal plan, Medicaid plan for the County of Orange. Now, Kaiser Permanente, our partners at KP, also participate in Medi-Cal in Orange County, but by and large, Orange County chose many years ago to have one plan manage all of its Medi-Cal health benefits for the county. And so that means that today we have about just under 870,000 of Orange County's residents who receive Medi-Cal under Cal Optima Health. There's probably another 50,000-ish with our partners at KP. So again, just about 900,000 probably in Orange County in Medicaid. That's 1 in 4 residents, and I know that that's a pretty standard statistic across California. It's it's been between 1 in 3 and 1 in 4 residents in California who have been receiving their health services through Medicaid, and that really highlights what we just heard about, the growth of the Medicaid program as a coverage option across the country and certainly here in Orange County. Children are even more impacted. In many counties, it's half of the children. In Orange County, it's a little under half, about 40% of our kids get their health care because of Medi-Cal. What this means for the local healthcare economy and the economy in general, Cal Optima Health has an annual budget of $4.7 billion, and we spend nearly all of that here in Orange County on our local healthcare ecosystem. We spend about 94 cents of each dollar here, and the 6% that we spend on admin is also spent largely on a local workforce of about 1,600 employees. Where do our healthcare dollars go? They go to about 10,000 providers, again, largely right here in Orange County. We have the great fortune of working in really a robust healthcare ecosystem here in Orange County, and a healthcare ecosystem that has embraced wanting to participate in the Medi-Cal program by large. I will say that right now we have about 30% of our membership is being covered through what we call a direct network, where we contract directly with the physicians and hospitals, and about 70% of our members are covered through 9 of our medical groups, where the groups are taking, these large medical groups are taking on financial risk to provide care for these members. And that matters because as we see the programs change, it also impacts these 9 large medical groups that play in not just Medi-Cal, but also provide healthcare through Medicare, through commercial insurance as well. So as we look at kind of what the impacts are to the changes, it's not just the changes through HR 1, but also the changes that we anticipate will come through state budget policy changes. We thought I wanted to share with you, again, some of the historical markers when it comes to Medi-Cal membership, the growth and trajectory of Medi-Cal coverage in Orange County, because we think that some of these are experiences that we will probably see repeated. We wanted to show again, what coverage looked like in the Medi-Cal program pre-ACA. That's kind of the line A, and you see that big increase. That was not only Medi-Cal expansion, but I think also, as JC spoke to earlier, that was also a shift in individuals who were being covered through other programs like indigent programs into Medi-Cal when, again, the Medi-Cal eligibility rules expanded. You kind of fast forward to kind of what you see here as B, that was around, we all remember this date in 2020 when COVID started. And not only did COVID contribute to the enrollment increases, but also as part of the public health emergency, redetermination ceased, was paused. And so you see that just continued upward trend where we hit almost 1 million Orange County residents who are getting services through the Medi-Cal program. And then between C and D, when redetermination, annual redetermination started again, you start seeing that drop. And again, JC spoke earlier to the administrative process. The state, the county, we work really closely with the Orange County Social Services Agency. A lot of effort put in locally to try to minimize the administrative losses of eligibility, and you still see, again, that kind of downward trend. You kind of see a stabilization that happened in 2024 because that's when California implemented the adult expansion of Medicaid coverage for adults between 26 and 49 without satisfactory immigration status. So we did see an increase in enrollment and coverage through that time. And then we only have a little bit of data for this year, but we started really seeing another impact of redetermination happening at around August of last year. We started seeing the enrollment decreases again. And we think that's partly due to a couple of factors. One is we've kind of hit the top of enrolling the newly eligible through the Medi-Cal expansion for the unsatisfactory immigration population. And then also, that's when we started hearing a lot about just immigration-related fears in the community, and it became more challenging. We heard that very loudly from our local partners who do a lot of navigation work. The challenge is in individuals being willing to go through that redetermination process. Those who had been willing before were no longer as willing. And then as far as the beginning of this year, again, we only have 2 months of data, but we are now at about 22,000 members, again, coming down from a high of just under 1 million 3 years ago. Again, we just heard that in terms of anticipated projections, we're working on our projections right now, but they're pretty standard across the board. I know the state had projected about 3.4 million statewide. We kind of use a marker of Orange County as about 6% of the state's Medi-Cal enrollment, as well as the budget. And it's pretty consistent throughout. We just saw the UCLA Center for Health Policy Research and UC Berkeley Labor Center released their county-by-county projections of enrollment losses. And for Orange County, they're projecting by 2028, 250,000 individuals losing Medicaid, Medi-Cal coverage, which is not out of line with the projections that we've seen. That's on the high side, but again, even if we took just a straight 6% across the state, that would not be particularly out of line. So when you think about 250,000 individuals, that's about 30% of our current enrollment. And then I translate that to what does that mean in terms of dollars, and that's $1.4 billion in Medicaid funding that's no longer coming into Orange County. Those are some real considerations as we do our planning. As we do our planning, we take a look at who is impacted the most in terms of, again, the enrollment trends. We call these 8 categories, but these are, again, the different types of populations that qualify for Medi-Cal under slightly different rules. You see under the green on top, that's our expansion population, our adult expansion population. And as we know that there are some new rules coming into play that kind of differentiate rules for an expansion population versus what's being called, or what has been called, a classic population. We've seen that a population enrollee decrease again steadily since redetermination started, but since about August of last year, when we started seeing that again dip again, that population has dropped nearly 10%. The orange is our children, and I think there's an idea that the child population is fairly safe, but children's redetermination follows very closely with their families' redetermination processes. And that administrative process, we've seen the child population drop about 6%. The only population that's steadily growing in Orange County is our seniors and persons with disabilities. That's that purple line. Those are our older adults, and again, our individuals with disabilities. That has been a steady increase of about 3% over the entire time. And then that last blue line that you see in the bottom, well, not the very low one, but the dark blue line in the middle there, that's our adult population. That tends to be parents of the children who are covered, and that's also seen a dip of about 10% over time. We have a pretty small long-term care population. These are our individuals who are permanent residents of nursing homes, and that has stayed fairly steady. It's a small population. The other, again, view that I wanted to share with you was kind of what we expect potentially on membership based on immigration status. So we have here, the top line is our members with satisfactory immigration status. The orange is our members with unsatisfactory immigration status, UIS. And so you've seen how, again, because of state policy expansions, that orange line kind of grew, kind of tabled, steadied out there, and then it's starting to decrease. It's hard to see the decrease there because, again, the number's there, but since July of 25, we've seen about a 12% drop in that population. It's about double the drop that we've seen in that same period for our members with satisfactory immigration status. And again, that we project may be related to, again, because, again, up until this time, you can't really see January, and it's hard to tell the difference. Until the January period, there was no change in who was eligible in either population. But we see the differences in individuals' responses to their redetermination requirements. So in terms of, I'm just going to go back to this one as a landing spot here. Just in terms of, we look at impact to providers, 200 to 250,000 individuals in Orange County losing Medicaid. Again, how many of those individuals will end up as uncompensated care? Many of the I spoke earlier about kind of who takes care, or who has the financial responsibility, as well as takes the financial, the revenue from these populations. The unsatisfactory immigration status membership, that sits much heavier in our direct network than in our delegated network, in our medical groups. And so we expect that at least there'll be a little bit of, on the provider side, then the medical groups will take a lower loss there than our direct network will. But when it comes to, again, the loss in the local healthcare ecosystem, a membership decrease of the magnitude that we're looking at right now is looking like $1 billion to $1.5 billion, again, leaving the Orange County healthcare economy. Impact to members, obviously access options, we heard a little bit about this, kind of the traditional places that we've turned to for uncompensated care, or again, uninsured care, have been the federally qualified health centers, the county indigent programs, and our hospital emergency rooms. And I think unlike in the past, our federally qualified health centers are dealing with different, again, policy barriers potentially on serving an undocumented or unsatisfactory immigration status population. Again, as alluded to earlier, county indigent programs are gone, are pretty much gone. They have to be kind of reconstituted, rebuilt, and that really leaves a big burden on our hospital emergency rooms. And that's really where, as a health plan, as a payer in the local delivery system, that's where I worry about, again, how do we protect that resource? How do we protect those partners? So kind of what's the plan doing in this space right now? Because that's pretty depressing right now in terms of what we're looking at. So what's the plan doing right now? I mean, I think the first thing that we've been really focusing on has been community information. There's a lot of just gates coming up when it comes to coverage changes. So how do we, as a local community, as a fairly small community, how do we get all behind some consistent information and support? We're also putting quite a bit of resources into navigation support, both supporting activities at grassroots levels, supporting activities at the county level. What can we do as a health plan to support helping individuals keep their Medi-Cal who are eligible, and again, not fall through administrative or paperwork holes, and also for those who don't qualify, who can help navigate them to other sources of care. I think planning and information sharing at this time is critical. We're all dealing with these changes. These are holes in budgets that no one entity will be able to fill. And so how do we share the planning together and then turn that into a local response? Again, we've had, since HR 1 passed, Orange County, local community has been really banding together to talk about how do we respond to this, and kind of what I think we have stressed, I think all of us have stressed, is this cannot become a food fight, because there is not enough to go around for everybody. So how do we prioritize as a local community to preserve coverage as much as possible, and then also preserve the healthcare assets that we have in Orange County? So I think with that, I will close and turn it back to Anna.
We have a decent amount of time, so I'm going to ask some of my questions, and then I do want to leave some time for audience questions, so we'll come back to you. But I want to start the conversation with what JC and James both mentioned is probably the biggest change for states, the changes in the provider tax provision. You both mentioned that this will sort of force states to come up with policy responses. And I know it's maybe still a little early. I know in Sacramento, this is exactly what's being discussed right now. How do you make up for those dollars? But I'm curious if we are seeing anything in response from other states, or what you expect to see in response to the provider tax provision and the dollars that will be lost for states there.
Well, I think it'll vary a lot by the states, but I've always been of the view that some of what's gone on in this space has been, well, they make this available, let's take it. And so there's been an element in some states, I'm not saying in all, but in some states that they find an avenue to recapture more federal dollars. And in a certain sense, their political process is such that their voters say to them, well, why aren't you taking advantage of that? Every other state is taking advantage of that. So there's pressure to do it. I think with this change, there's going to have to be a reevaluation of the things that they're financing through the ones that are going to be restricted going. By the way, it's not going to zero. It's kind of basically being cut half to 2/3 from the baseline. So it's still going to be allowable, but just at a lower level. The states are going to have to look at that and say, we were spending, I don't know, X dollars through these kind of mechanisms, of which 25% maybe we actually didn't really need to do, but we just kind of kept going with it because the dollars were available. But the other 75% is critical to our infrastructure. And therefore, we're going to have to find revenue in our budget to pay for it, or, ask providers to take a lower payment rate. They'll find different mechanisms for prioritization. So my basic view on this is it's a shock to the system, but it will get recalibrated probably over a 3 or 4 or 5 year period, and there'll be a new normal. And the new normal, while maybe not be quite as easy for the states to manage, I think will be acceptable. That's my expectation.
JC, you have a relationship with states. States are already, at least in California, what I know is we're already facing budget pressures. So in terms of actual actions, what are you expecting? Are we talking about those cut in enrollment and services? What could be, coming?
Well, at least the managed care tax, in California, the biggest taxes are going to be your managed care tax and your hospital taxes, right? And so right now, the managed care tax is paying for rate increases. That's what it pays for, 100% of it dominantly. There's some things around the edges, as we all know, but that's what it's dominantly paying for. And so I actually really agree with what James, states are gonna have to make decisions. And California was using a lot of general fund and Medicaid for other things. They used the tax dollars to pay for the rate increases. There will be decisions that have to be made in the future around what are you funding with your dollars, and can you afford your program, for lack of a better description, right, with general fund. So I think all of that is 100% right. States will have to live within a different budget, to be honest with you, to do those things. But depending on where things fall and if things really play out, states only have so many options. You can cut coverage, which is already being cut here. You can cut benefits. You can cut rates, which already de facto will happen most likely. The other thing is state-only programs, and that's what you see California doing right now. They're shrinking the coverage with state-only dollars on the UIS population, because those are your 4 ways that you can do stuff, and not all states have big state-only programs. California does, and so they will have to look across all of those options. But the interesting thing about California is they were putting significant general fund into their Medicaid program as well. So instead, in the future, new programs, they would most likely need to shift those general fund to support what they would consider a base program. And this is what a lot of states are talking about right now. In light of this, where you put risky dollars will significantly change. And so what does base Medicaid look like? You can't just look at what's mandatory in Medicaid and not, because pharmacy is not mandatory in Medicaid as an example, and cutting pharmacy would probably cost someone a lot of money if you're not having those types of pieces. But really, what is your base? And then anything that you're doing with risky dollars, whether that's 1115 or provider taxes or other pieces, because of the swing that could happen, you have to be really strategic around what you're funding with those pieces. And so I do think you will see a fundamental shift of how states manage their Medicaid programs, how they fund them, and it will take time. So I actually really agree with the shift that was described by James as well.
You mentioned also that, about 3.4 million are expected to lose coverage from Medicaid in California through all the HR 1 provisions. I'm curious if we can talk more about what exactly this would mean for hospitals, counties. I know you mentioned a little bit on that, but those people still need care. They need to go somewhere. They're going to go, as we know, probably the ER. So big picture, what are we looking at in terms of the impact for more locally, at the county level?
Yeah, it will interest you to see how it actually hits in the numbers that hit. But yeah, I mean, the hard part is you have hospitals who are going to be one of the largest people impacted by the financing changes, also being hit with coverage changes. So they're not going to have extra dollars to make up for uncompensated care or someone who's walking into the hospital uninsured. It's not going to shake out. Most likely they're going to try to put pressure on the managed care plans to increase their rates, but there's no way managed care plans with what they get paid in California are going to be able to make up for those losses. They could put pressure on the state of California to do that as well, but given California's current budget picture, California is not going to be able to make up for those losses as well. So everyone's going to take a haircut, for lack of a better description. And so, yeah, people are going to show up most likely in emergency rooms. We know that's typically what happens for uninsured. And this is where the 17,000 statute will come in California. Counties have an obligation in California to step into that role. It'll be interesting to see what they end up covering and or don't, what federal poverty level they go up to. But you're going to see that uncompensated care increase. You're going to see hospitals closing or already talking about closing different wards of their hospital, ending certain service lines, right? So you will see impacts in the system. I think rural hospitals and critical access hospitals, especially in California, people don't realize we have 2 million people in rural areas of California in Medicaid. That's a lot of people in rural parts of California that could lose access as well. And so and those are going to be in counties where the county will not have the funds to meet the uninsured expectation of that county, because smaller rural North Frontier counties are not going to have significant dollars to meet their 17,000 obligation, right? So it's just the pressure will be very real, I think, for hospitals. There'll be a lot of pressure on plans. The state to kind of navigate this, the program will have to shrink to be able to afford it, to be honest with you. I don't see another way forward there. But a lot of really big, hard decisions in front of people in California for sure.
Can I say
Do you have
something?
anything? Yes.
I have a couple of thoughts about. It's not in disagreement, actually. Just a couple of other data points that might be helpful to keep in mind. One is that, yes, there's big changes were enacted in the 2025 bill. I do agree generally that they're the biggest changes in Medicaid in a very long time. But the baseline of Medicaid spending is going up a lot. Okay, so just to put this into perspective, the CBO just put out their latest baseline estimates. If you just took all federal spending, took out net interest, because that's just sort of servicing existing debt. You just said, what was spending on all of the rest of government non-interest spending in 2026? Here's what it is. It's a big number. And then you just kept that as a nominal freeze for 10 years, no growth. And you compare it to what they actually expect to occur for that category of spending. 88% of the growth, which over 10 years is going to be, I think, $13 trillion. 88% of that $13 trillion is 3 programs: Social Security, Medicare, and Medicaid. So Medicaid is not going down. It's not going to be decimated. It's not going to zero. It's going to grow. It's going to grow probably by 5 or 6 or 7% per year. Secondly, it's true that California will likely have lower numbers of enrollment in Medicaid. But remember, even on the CalOptima charts, it was only a few years ago where they were, 20% smaller than they were 6 months ago. So there's been a lot of growth in the program from 2020 to 2024. Was all of that absolutely required for the functioning of American healthcare? It'd be hard to argue that. So reinstituting redeterminations is bringing the numbers down, but that's because the people aren't qualified for Medicaid. So yes, there's some that get discouraged by it, but there's quite a lot of people on the program that aren't eligible for it. So then the question is, what do we do about that? I think, by and large, I don't support the work requirement provisions. I thought they were just sort of too much, not really necessary to what Medicaid's purposes are. But the other provisions of the law are largely tightening up things that had gotten way too loose. And it's not going to decimate Medicaid. It's still going to be a gigantic and growing program. And so I think a little bit of perspective about where this is going is probably in order. My guess is you might see headlines several years from now saying, hey, states weathered the Medicaid storm. That's my actual, maybe you bring me back in 10 years and we'll see.
Yeah. So that brings me sort of to my next question, James. Maybe I think what you're alluding to, there is this argument that Medicaid, as you're making, is too big, and that this will force states, to tighten their budgets and really focus on exactly what's necessary. I'm wondering where you think some of those haircuts, as I think was the word mentioned, would happen. Like, what exactly can we or can states, get rid of or reduce in their programs that you think is, not necessary?
Well, let's start with making sure there is absolute integrity on the enrollment processes. I agree generally with not putting overly burdensome requirements on people. I do like more continuous coverage. I like year-long eligibility. But having said that, there's quite a lot of enrollment that went into the program that, as soon as someone comes along and says, hey, we need to go back and check everybody, all of a sudden, lots of people fall off. So there's something going on there. It's too loose. So you're going to have some integrity in the enrollment process to make sure people who are on it actually are eligible, even under the state's own rules. And then, kind of do have data that checks and makes sure that occurs. I think also there needs to be more openness to new ways of channeling the patients. I'm sure CalOptima is very innovative, but not all Medicaid programs around the country are the same and innovative. There's a lot of stagnancy in how services are delivered. I think new methods, lower cost, more emphasis on getting people out of the emergency rooms of America who are on Medicaid, which is still elevated relative to the insured population. There's a lot of work that can be done there. And candidly, there's a lot of hospital systems still that come forward and they say, Medicaid in our emergency rooms is a source of revenue, which is really a problem. So there has to be some shifting, and it's not every state, but there's a lot of places in the country where it's still a very major point of access to the general system. And that's expensive.
Yunqing, for the folks, and I'll open up to audience questions after this, but I'm curious, for folks who, what is CalOptima doing to help folks stay enrolled, for the folks, that are eligible for the program? What is the plan's role in all of this? I know counties and the state are usually in charge of all the renewals, but what is the role of the insurance plan here?
I think the health plan plays a big role in this. So locally, kind of some of the things that I mentioned is we're trying to get out ahead in terms of just making sure that as a local community, we're all working with the same information. And that's not only what's coming, what's changing, when is it changing, but also sharing data. So we are working with our county to identify who is up for redetermination, when, and how do we all know that so that we can support that individual to either go through the process, or again, if they're not eligible, then how do you navigate them to something else, some other source of coverage or some other payment source for healthcare. So that's kind of one thing that we're doing. We're doing supporting navigation. We're actually putting significant funding into navigation. We're funding local organizations to help individuals with their redetermination, as well as with actual enrollment for anybody who does qualify, help them go through that process, because it's not an easy process. It's not a simple process to either get in or stay in the Medi-Cal program. And if you have to do this twice a year now, that's just more chances for folks to either be discouraged or to just miss that opportunity. So funding local organizations to do that navigation. We're actually funding our local county social services agency to be available at all of our weekend events, our community events, and actually do enrollment or redetermination on site. Because at the end of the day, the only entity that can press that button on that application or redetermination form is the county eligibility worker. So supporting that effort, but getting the individual to that point could be a doctor's office, could be a pharmacy, could be a clinic, could be us. So again, supporting all of those areas. And I agree that there are opportunities in this system for tightening across the board. There's tightening opportunities in eligibility. We're seeing some of that audit activity already happening. Program integrity, we're all feeling that already at the local level, at the plan level. We're seeing that. When it comes to the benefits, there's opportunities to tighten up benefits. And so we'll be looking at that. Where is there flexibility for a plan and a local community to determine what has the most impact, what has the most ROI, what can we keep, and what can we live without, even if that's unpopular. And then, yes, you're right, provider rates, and that's why it worries me, because we've gotten used to a certain level of funding across the board that we're going to all now have to get used to a different level of funding across the board.
Thank you. I think we have a few minutes for 5 minutes for a few questions. So are there microphones or anybody wants to raise their hand if they have a question?
Thank you. So all morning we've been hearing about haircuts here and haircuts there. Now, we all agree that $5.3 trillion is unsustainable. So looking at it from somebody who's trying to see the future, I know I know what we're gonna do, but what's the destination? What's the new normal? Is it just fiscal responsibility or living within our means, or is there a destination that we're going to that's more policy driven? Can you share what you see as the new normal, perhaps?
Is that question directed? I think you were talking toward me. A little bit hard to see because of the light, but is that for me, I assume? Yeah, or to anybody? Did you, yeah.
You want me to go?
You could go first.
Sure.
Yeah, I didn't, yeah.
I mean, I think it's the new normal is I do think there will be less overall funds, yes, but I also think it will be hopefully a good thing for the delivery system. I'll be honest with you. I mean, I think there's all kinds of things that could be tightened up in healthcare, to be honest with. There's a lot of waste across the board. I think this will be the catalyst to really start using that. I think technology will come in very real ways and hopefully be harnessed to start looking at some of the overall administrative burden and waste that could go away in healthcare. There are appropriate things to be trimmed. The hard part about the things that really need to be trimmed, they're the hardest things to trim so it doesn't happen overnight. But you kind of need something to kind of motivate people to make larger change, to be honest with you. And so there's a lot of things I don't love in HR 1. I can say that for sure. But I do actually think there are some opportunities as well to start thinking differently around fiscal pieces, but also how we administer healthcare, and in particular Medicaid. It's overly complex. The amount of money we spend on admin burden is real. It's only burning out providers. And we need providers. We can't lose access to that. So I think there are some opportunities in it all too. Hopefully that's where it can go. You have to be careful because if you cut too much too fast, people don't have the capacity to make change like that, which would be needed to be able to sustain these cuts. So it's like it's all about a balance and how fast you make that financial cliff, because there could be some opportunities here.
In terms of what's the landing spot? Is there some vision for where this might go? I think you could see that in our politics, it's probably going to have to come through our political discussions and debates, because it's the health system with Medicare and Medicaid and the ACA and so much history around all the regulation that has flowed from those big programs. The federal government's knee deep into this whole thing, kind of no matter which way you turn. And so it's inevitable that some landing spot or discussion of how we should land is going to be part of a political discussion. And so, the next presidential cycle is probably when a Democratic candidate says, here's where we need to go, and a Republican candidate says maybe nothing. I don't know. So, that's, I think, where it might get litigated. And then the voters get to decide if they like where it might land based on one vision or another. I would want to say this, though, that I think overall the U.S. system is excellent in a lot of ways, adaptable. It's open to technology and innovation, which actually might be part of our way out of the mess we're in. But the last point is that I know I'm being told to stop. So it's, there's a lot of productivity improvement available, but the incentives are very poorly aligned.
Okay, I know there were more questions, but we are being told to stop.
STOP. It was capitalized.
They gave me the microphone, so I guess I get to ask my question. JC, you were talking about how this redetermination is causing people to drop off and lose coverage, and that's causing increased churn in the system, and how many extra dollars that adds and how much cost that adds to the system. My question is about the 1115B, the waiver. And first of all, I guess, how much are those programs at risk with HR1? Are we still going to have them? And if we lose those programs, is it going to be the same kind of thing? How much bang for our buck are we getting from those programs is what I'm saying. Is, if we lose those, is it going to end up adding costs, or is it going to end up being a net savings?
Well, so I'm assuming what you're talking about is like the community supports.
Community supports,
Yeah.
Housing, meals.
So the majority of California's community supports are in lieu of services. It's in managed care authority, and California is required to submit a report to the federal government that they're cost effective. So right now they're actually showing as being cost effective, which means they're actually saving dollars. To be honest with you, it's different. A lot of people who do it in 1115s, they don't have to have that same report, so that it's actually more extensive. The two that are at risk are in the 1115 is recuperative care and short-term post-hospitalization. And that's what California is potentially, is currently out in their renewal to propose to move those to in lieu of, but to remove the room and board from those, which means the rate will come down a little bit from that perspective to preserve those. We have opened hundreds of recuperative care and short-term hospitalization beds across this in facilities across the state of California. And that is, to me, that is a real threat. I'll just be honest with you. To have somebody someone experiencing homelessness languishing in a hospital bed for 6 months, which used to happen, for the record, before those things, with no place to discharge out to, and any doctor not willing to just discharge them to the street, you pay a heck of a lot more for someone to sit in an inpatient bed than you do to go to a recuperative bed. So if the federal government cuts that, it would be very foolish, to be honest with you, because it is bread and butter when it comes to return on investment. Now, maybe not all are that way, so you may have to slim. I do think we've probably overpaid for some of the food pieces. We need to tighten up eligibility. It needs to be closely tied to clinical orientation and link. Medicaid's not here to cover food insecurity. Food insecurity is really important, but there should be a clinical intersection with the eligibility of who's getting that when Medicaid's paying. So I think you're going to see a little bit of both, to be honest with you.
Great. Thank you.
Let's thank the
you.
panel. That was a very lively discussion.